Now moving on to the lower limb injuries. As we know that peripheral nerve, there is a lumbosacral plexus which supplies the lower nerve. There are many important nerves such as obturator, femoral, and sciatic nerve. So now we will be moving on to the peripheral nerve injuries of these nerves. In this section, we will briefly go into the lumbosacral plexus, femoral nerve and peroneal nerve injury, and tibial nerve injuries. So what is the lumbosacral plexus? It is actually formed from the lumbar and sacral rootlets. As you can see over here, it starts from the L1 and it all the way goes back to S2. And before that, there's all these nerves are actually formed as in upper arm there's a brachial plexus, in the lower arm there's a lumbosacral plexus. Nerves which are mainly coming out is iliohypogastric, ilioinguinal, genitofemoral, lateral femoral cutaneous nerve, saphenous nerve, obturator nerve, and femoral nerve. That's why it's important that all these actually have importance differently as well. So this is usually the most common mechanism of injury is always the massive pelvic trauma. Like in case of a vertical shear fractures in which one half of the pelvis is actually rerouted and moves upward, or in the severe type of APC type 2 injury in which there's anterior posterior compression and this results in nerve damage, or a lateral compression and results in this kind of an injury. There's maybe incomplete or missed lesions, which usually if it's there could be a firearm injury as well, which can nerve the specific nerve roots as well, not whole of the lumbosacral plexus. Associated with muscle weakness and lower limb dermatomes are usually affected. As we know, mostly it's the inguinal region as L1, with the sacro S1 and S2 are usually on the lateral aspect of the foot. Surgery is rarely undertaken unless the major nerve is involved. Now coming to the femoral nerve injury, as you know, its course is such that it can be compressed in multiple areas, and it's formed from the upper part of the lumbosacral plexus as the L2, L3, L4, and once it forms, it descends down along with the iliopsoas muscle, where it either crosses the pelvic brim and comes down into the thigh. It can be injured by a gunshot, it could be a pressure or traction, usually rarely formed, but if in case of anterior dislocation can result in this kind of a damage, or a gunshot straight into the thigh can also lead to femoral nerve injury. It supplies the quadriceps for the most important muscle which gets affected is the quads muscle, and as the iliopsoas is affected and quads muscle are affected, this usually results in loss of flexion at the hip joint and extension at the knee joint. There is numbness of the thigh because this area of the L2, L3, L4 dermatome is usually involves the middle of the thigh, and lateral part of the knee. Knee reflex, that is the quad reflex or extensor tendon reflex, is depressed or lost. Neurogenic pain is usually associated if there is some degree of nerve regeneration. There is always associated with neuroma and nerve pain, but if it is a complete injury, usually associated with no pain at all. Now, the important point is if there is a gunshot injury or if there is compression due to hematoma, evacuation needs to be done. And when we are dealing with these kind of injuries, especially in the femoral vessels are also involved, it's important to give pressure dressings in these cases, because usually when in emergency the arterial clamping is being done, there's always a chance that nerve injury which was not initially which did not happen initially, there remains always a chance to stop the bleeding from the femoral nerve or femoral artery. There may be associated with decrease, or this may result in injury to the femoral nerve. Now coming to the peroneal nerve, it's as you know that it's a sciatic nerve passes from the thigh, from the sacral plexus back into form a common peroneal nerve. This common peroneal nerve then splits into two. This eventually calls as the deep peroneal and superficial peroneal. Now the clinical features include usually of the common peroneal nerve includes the damage at the level of the fibular neck. Now this is where it can get damaged, especially in case of fibrotibular dislocation, or there may be associated fibula fractures which can damage the common peroneal nerve. This may be due to traction when the knee is forced into varus, for example, in case of reducing a dislocation. Eventually, if even if initially the injury did not occur, this may result in iatrogenic injury. This could be due to pressure from the splint, especially if any splint was applied for the treatment of knee injuries. There may be a nerve avulsion as well, and usually superior tibiofibular joint ganglion can damage this as well. This usually results in foot drop, that is, the person is not able to dorsiflex his foot during the gait cycle, and this is called as foot drop. As a result, the mechanism being applied by these patients is such that they usually have a high stepping gait, because so that the foot is cleared off the ground in a high fashion and a high step way, so that even the foot drop does occur, the toes does not actually touch the ground. Now, the other features is the peroneal nerve, as I've just mentioned, is usually these are the areas around the some superficial part of the lateral thigh, and some part of the knee is actually supplied with the common peroneal. Then this is all areas supplied with superficial peroneal, and deep peroneal supplies the skin of the between the first and the second toe. Deep peroneal nerve is at a lower border of the ankle extensor retinaculum. This is where it can get damaged. Usually it is threatened in the anterior compartment syndrome as well, because it goes all the way into the anterior compartment. There may be pain and weakness of the dorsiflexion resulting in a foot drop and sensory loss of the area which I've just mentioned over here. There is paresthesias and numbness may be associated as well. Then there is superficial peroneal nerve descending along the fibula. This superficial peroneal nerve is actually, when it bifurcates into superficial and deep peroneal nerve, the superficial remains most lateral and superior as well, and usually it supplies only a very small part of the it's a muscle, that is only the peroneus longus and the peroneus brevis, but mainly the skin is supplied on the anterior lateral aspect, is mainly supplied with superficial peroneal nerve. Involved in the lateral compartment syndrome, that is if these are the muscles which are affected, usually resulting in pain, numbness and paresthesias. And as the peroneus longus and peroneus brevis become atrophied due to loss of this superficial peroneal nerve, there will be loss of eversion and sensory loss as well. And severe inversion injury of the ankle may occur as this result as well. Now, coming to the treatment. Treatment of as any nerve is that we have to decide whether it's an acute injury or a chronic injury, and do we need to acute repair or delayed repair. Direct injuries, for example, could be damage treated by grafting a splintage, or if it's more than 6 months, then tibialis posterior tendon transfer can be done, and hindfoot stabilization can be done in the form either of ankle foot orthosis, or it could be from subtalar orthodesis or tibial-talar orthodesis. If it's a traction injury, this usually initial treatment could be simply grafting or splintage, and then we, depending upon the time period, whether some kind of nerve grafting can be done or not, or then if it has more than 6 months, then the answer is the tendon transfers, and most commonly it is always either tibialis posterior, flexor hallucis longus. Now, coming to the tibial nerve. As you know, the sciatic nerve enters into the popliteal fossa, where it continues into the leg as form of a tibial nerve. And there are two compartments in the leg behind the knee, that is the superficial compartment which contains the gastrocnemius, and the deep compartment which contains mainly soleus and other muscles. It's actually this, the loss results in unable to plantar flex the ankle or the toes, but this would still result in a kind of a foot drop, because the plantar flexion, although gastrosoleus complex is paralyzed, it really results in atrophy. But once the patient will take the step during the swing phase of the gait, due to gravity, the foot would drop. But this would usually result in this same kind of a pathology. There is a loss of sensation over the sole and usually over the posterior aspect of the thigh. There is atrophic and pressure ulcers which may be seen especially over the heel and these areas. And there are tibial nerve actually divides into two, that is posterior tibial nerve, which is just behind the medial malleus, goes and gives off small calcaneal branches, wide sensory loss, and usually resulting in toe clawing, because the intrinsic muscle of the mainly it's supplied with the tibial nerves or the posterior tibial nerve. Then there's another nerve called as lateral, or it's called lateral plantar nerves, which is actually rise from these nerves from the lateral tibial nerve, but they are mainly the one which are supplying the muscles of the intrinsic muscles of the foot usually. And if they are lost, this usually results in fibrosis and clawing of the toes as well. Coming to the treatment, if the tibial nerve is lost, then how we can treat it? That's simply depending upon if it's an acute injury during a surgery it was lost, the best option is just suture it back for the iatrogenic injury. Other is suitable orthosis such as ankle foot orthosis can be done as well. Then we, especially as his heel needs to be protected because Catasaurus is actually atrophied, therefore special sole protecting shoes in case are specially given in which the heel is mainly protected. The other option is hindfoot fusion in form of subtalar or tibetalar orthodesis, and the last is actually the transfer tibialis anterior tendon back to the well, so that these can be utilized. Some degree of plantar flexion is achieved by this transfer. In this section, we have gone through how to treat the nerve injuries which are associated with peripheral nerve injuries of the lower limb. We have briefly gone through the anatomy of lumbosacral plexus, and we have seen how the femoral nerve can be injured as well, and what are the effects of femoral nerve injury. We have briefly gone through that usually if it's iatrogenic injury, we need to treat it acutely, but usually the delayed repair is done, which is in form of grafting or simply splintage of the muscles and joints, and then we can later on now, and if not nerve transfer is not possible, then we can go for tendon transfers. Usually the tibialis anterior or posterior is used for transfers. That's all from this section. Thank you very much.